Everybody to our presentation regarding chiropractic treatment and the Minnesota Workers' Compensation System. I'm a nurse case manager here at Corvell. I have been a supervisor and managed care manager here, and I've been with Corvell for 19 years. And although Dr. Flood will not be presenting with me, he has been an assistant and advisor regarding our presentation. And he is also included in the information we have here, and this is presented by Corvell Certified Managed Care. So the goals here are to find the statutes and rules regarding chiropractic treatment in the Minnesota Workers' Compensation System, the first one. Secondly, to have knowledge of the Minnesota Workers' Compensation rules regarding chiropractic treatment. And thirdly, to have the ability to apply the Minnesota Workers' Compensation treatment parameters to chiropractic treatment. So first of all, the revisor of statutes, this is where you're going to locate statutes and rules. The difference between statutes and rules, the statutes are a compilation of general and permanent laws of the state. The administrative rules are the general statements that are adopted to make the law it enforces more specific. And then what I've also included on this screen is the link that will take you to the rules. It'll take you to Chapter 5221, which is called the fee schedule, but embedded in 5221 are the treatment parameters, the Minnesota treatment parameters. So as you can see, when you go onto the Revisor of Statutes page, you will see the Minnesota rules. I pulled up Chapter 5221. If you look at my cursor, you can enter in where it says retrieve by number. You can enter in any other type of number that you need to search for, and the drop down here will give you a choice between statutes, rules, laws, etc. And so, because if you're pulling up a statute and you still have rules listed in there, the search will not be successful. So the treatment parameters, as I said, are embedded in the fee schedule, and they're included in the rules that begin in Chapter 5221. They're included in the rules that begin with 6,000. So all the rules from 5221 6010 through 5221 6600 are the Minnesota treatment parameters. We're going to go over some parts of these rules. In 6040, there are definitions. Subpart 2 has a definition for active treatment, which requires active patient participation in a therapeutic program. And you're going to see that there are a lot of different rules for passive treatment and injections, etc., that require active patient participation in a therapeutic program. This doesn't necessarily mean that somebody needs to be involved in any kind of land therapy, that's active. It's just they should be involved at least in a home type of exercise program that they're continuing. Another definition we thought would be helpful to review is in Subpart 7 of 6040, and that is a definition of functional status, which is the ability of an individual to engage in activities of daily living and other social, recreational, and vocational activities. So it does include vocational activities, which would be their work status. The definition under Subpart 10, which is very critical to this presentation, is a definition of medically necessary treatment. As noted, it says it's health services for a compensable injury that are reasonable and necessary for the diagnosis and cure or relief of a condition, consistent with any applicable treatment parameters. And then it also says, though, that where the treatment parameters don't govern, the treatment must be medically necessary and appropriate according to the current accepted standards of practice. So you will note that the treatment parameters do have some specific treatment for the low back, the thoracic, the neck, and the upper extremity, as well as chronic pain. But it's not possible for the treatment parameters to cover every type of condition that's going to be incurred by somebody that has a work injury, and so that's why where the treatment parameters don't govern, it has to be according to the accepted standards of practice. The definition of passive treatment in Subpart 12 includes bed rest, thermal treatment, traction, acupuncture, electrical muscle stimulation, braces, manual and mechanical therapy, massage, and adjustments. I underlined massage because we are going to address that later on in the presentation because there are some idiosyncrasies with massage therapy in the work comp statutes and rules. In the general treatment parameters under 6050, it states that all treatment must be medically necessary. Medical necessity must be evaluated on an ongoing basis and consistent with accepted medical practice. And at each visit, the provider must evaluate if the treatment is effective. Effective treatment means that the patient has progressive improvement in two of the following areas. Subjectively, so the patient is stating that they're getting better and verbalizes changes in the symptoms, that are improving. Objectively, the provider is documenting objective findings showing improvement, or functional status is improving. So for instance, you may have somebody who is off of work that is now released back to work with restrictions, or maybe their restrictions are improving, or maybe they are going from being restricted to full duty. The rules state if there's no improvement in 2 out of the 3 above areas, the modality must be discontinued. If the therapeutic modality was tried and failed, another provider may not use that same modality. Another rule states it's inappropriate for 2 healthcare providers to provide the same treatment concurrently. So in continuing with the general treatment parameters, in subpart 1C also states that the healthcare provider must use the least intensive setting appropriate and also must assist the employee becoming independent in their own care, so that prolonged or repeated use of healthcare providers and medical facilities is minimized. Also, the general treatment parameters address documentation. In subpart 2, a healthcare provider must maintain an appropriate record that substantiates the nature and necessity of the service being billed and its relationship to the injury. In subpart 7A, again in the general treatment parameters, this is very important. Treatment is excessive if it's inconsistent with an applicable treatment parameter, or it is consistent with the parameters but is not medically necessary. So you may have a parameter that says for the low back, a person is allowed to have adjustments at a maximum duration of 12 weeks, but just because the parameter says that doesn't mean that it's medically necessary. So it still has to be medically necessary. Departures from the treatment parameters are also noted in section 6050 that deals with general treatment parameters. So a departure is allowed if there's a documented medical complication, or if the previous treatment did not meet the accepted standard of practice, or if the treatment is necessary to assist with initial return to work, where the work activities place a stress on the part of the body affected by the injury, and in that case, the provider must document the specific work activities placing the stress and the details of the treatment plan. Departures also allowed if treatment continues to meet improvement in 2 of the following areas that we talked about: subjective, objective functional improvement, or if there's an incapacitating exacerbation. We've had situations where people have had, gone through their passive treatment and they have had an incapacitating exacerbation, and so a departure was allowed for them to have treatment that was beyond what the treatment parameters had allowed. Also in Chapter 5221, Section 6050, there are some rules regarding prior notification. Prior notification to the insurer from the provider is not required for all treatments. It's not, and I have some of the exceptions or requirements listed here. First of all, it's not required for emergency treatment. So somebody who needs emergency treatment, you don't need to give prior notification for that. So emergency room treatment, et cetera. It is required for the chronic management modalities. It's required for durable medical equipment. It's required for non-emergency inpatient hospitalization and non-emergency inpatient surgery. and it's also required for treatment that departs from a parameter. Although prior notification is not required for all treatment, Corvell case managers do review and certify all treatment per the Minnesota treatment parameters. So, for instance, I had gone over this next rule, the 60-20 subpart 1. The purpose of the treatment parameters were to establish parameters for reasonably required treatment of employees with a compensable work comp injury to prevent excessive services under the Minnesota statutes. And I put that in there and underlined compensable because although prior notification is not required for all treatment, there's an advantage to the provider of working with the Corvell case manager when we're certifying treatment, requesting records, and reviewing the treatment parameters, because even though you might be providing treatment that doesn't require prior notification, we will also always verify if the claim is compensable and the body part's covered. So you know that when we send out a certification letter to you, we have already reviewed that that claim is accepted. You don't want to be in a position where you're assuming that prior notification is not required, but you're ending up treating a claim that was not accepted, or you're treating body parts that weren't accepted under the claim. We don't have the authority to certify treatment for non-compensable injuries or body parts. So that's why I wanted to point that out, that the treatment parameters only apply to compensable work comp injuries. And when you work with a Corvell nurse case manager and you get our certification letters, you know that we've already verified with the adjuster that that claim is compensable, and we've verified the body parts covered. So in the Minnesota treatment parameters, as I said before, they don't address all injuries, but there are sections that do address treatment for the low back, for neck, for thoracic pain, and upper extremity disorders. These three sections have some very similar treatment parameter guidelines, and I will note these on the following slides. So for instance, the following treatments are not indicated beyond a maximum 12 weeks of treatment. So adjustment or manipulation of joints, thermal treatment, EMS, mechanical traction, acupuncture treatments, manual therapy, and phoresis. So for adjustment or manipulation of joints, in all of these four sections, for the low back, thoracic, the neck, and the upper extremity, it says there should be a treatment response after 3 to 5 treatments. The maximum frequency of treatment is up to 5 times a week for 1 to 2 weeks, and then decreasing frequency, and then the maximum treatment duration is 12 weeks. For thermal treatment, again, the treatment response should be within 2 to 4 treatments. Again, there's a maximum frequency with decreasing frequency and a maximum treatment duration. For EMS, the same thing. You have a treatment response that's listed in 2 to 4 treatments. There's a maximum frequency as well as a requirement for decreasing frequency, and a maximum treatment duration, again, of 12 weeks, but only in conjunction with other therapies. Home use may be prescribed at any time. The treatment parameters do allow 1 to 3 visits to set up and educate people on home equipment. Okay for 1 month, and then requires reevaluation before with continued use. Mechanical traction, not for the upper extremity disorders. So in the rules for the neck, the low back, and thoracic, you want a treatment response in 3 treatments. Maximum frequency is up to 3 times a week for 1 to 3 weeks, then decreasing, and again, your maximum treatment duration. And again, there's some addressing home use of equipment as well. Acupuncture treatment requires a treatment response in 3 to 5 sessions. Maximum treatment frequency is listed with a decreasing frequency. As you can see, there's a pattern here. For all the passive modalities, there's a treatment response time, there's a maximum frequency, and expecting a decrease in frequency and a maximum of duration. Same thing with manual therapy, a treatment response, frequency, and duration. Phoresis, the same thing. It's a little bit more specific with the lumbar and the upper extremity in difference between the cervical and thoracic. Now, there's the 12-12 rule that is also in all 4 of these sections. There are requirements that need to be met before a provider can proceed with treatment, though, under the 12-12 rule. The 12-12 rule says that additional 12 visits of passive treatment are allowed, and these are 12 visits over 12 months. And that's why it says the 12-12 rule. It's not 1 visit a month, it's 12 visits over 12 months. So you could have 6 visits in the first 2 months and do the remaining 6, the rest of the year. The additional 12 visits are allowed if the employee is released to work or permanently totally disabled, the treatment results in progressive improvement, and there's a maintenance of functional status. The second requirement is that the treatment is not regularly scheduled, and that's very important. So when a person comes in for one of these visits, the doctor's notes can't say come back in 2 weeks, or the person can't be told to come back in 2 weeks. It's to come back as needed. The next one is that there has got to be documentation of a plan for independence to wean off of care and become independent of care. The treatment must include active treatment modalities, so at the very minimal, the patient should be involved in a home exercise program that the patient is actively participating in. The treatment must not delay surgical or chronic pain evaluation, and it is not appropriate for somebody who is with chronic pain syndrome. Active treatment modalities, there's a section in these 4, there's a rule in these 4 sections that deal with the back, neck, the upper extremity that address active treatment modalities as well. And they can exceed beyond 12 weeks of passive treatment as long as the maximum duration for the active modality is not exceeded. So if you have both passive and active treatment starting at the same time, they're both going to reach 12 weeks at the same time. There's also some treatment parameters regarding education. There's training for posture, biomechanics, and relaxation. There's maximum treatment of 3 visits and some follow-up visits, 2 follow-up visits. For active treatment continued, there's posture and work method training. The rules also indicate that they are allowed 3 visits. There's rules regarding worksite analysis to examine the patient's workstation tools and job duties. And again, maximum is 3 visits. And then there's also active treatment modalities regarding exercise. It must be aimed at the involved body part. There should be ongoing evaluation regarding whether or not the goals are being attained. Supervised exercise, the goal is to teach self-management, maximum frequency of up to 3 times a week for 3 weeks, maximum duration, again, 12 weeks. And then for unsupervised exercise, they do allow 3 visits for instruction, and obviously there's no limit on the duration or frequency of home exercise. Massage therapy, I wanted to go over massage therapy because if you noted earlier, massage is allowed as a modality. It was listed in the definitions of passive treatment. The tricky part with massage therapy is that the work comp statutes restrict who can provide massage therapy. So as I noted in the treatment parameters under Section 6040, the definition of passive treatment does include massage. And if you look into the passive treatment parameters for the low back, for the thoracic, the neck, and the upper extremity in subpart 3, massage is included in passive treatment. The tricky part is that under the statutes, and I listed it at 176135, it talks about complementary and alternative health care providers and states that services provided by an unlicensed complementary and alternative health care provider or practitioner are not compensable. And 146A gives the definition of complementary and alternative health care practices, includes massage and massage therapy. So massage therapy can be allowed if the massage therapy provider is licensed by a health-related licensing board or the massage therapy provider is working for and billing under the tax ID number of a licensed provider, a provider who's licensed by Health-Related Licensing Board. They cannot just be renting space in the provider's office. They've got to be billing and working under the tax ID number of that licensed healthcare provider. And right now, massage therapists do not have mandatory licensing by Health-Related Licensing Board in Minnesota, for instance, as chiropractors do, and nurses, and doctors, and physical therapists, and occupational therapists. And that's where it gets tricky. Massage is allowed as a modality, but massage therapists are not licensed by Health-Related Licensing Board. We have found that there are many massage therapists that are working and billing under the tax ID number of providers who are licensed by Health-Related Licensing Board. So, for instance, physical therapist facilities or some chiropractic facilities, and so in that case, we are able to allow them. We can't include massage therapists in our Certified Managed Care Network because we're not able to credential them because they're not licensed by Health-Related Licensing Board. That whole area can be very tricky and confusing. I also wanted to talk about the primary treating provider. A chiropractor can be the primary healthcare provider for an employee's injury, or you may have an MD who is the primary treating provider that is referring the patient to a chiropractor strictly for the modalities, the adjustment, modalities. The definition of a primary healthcare provider, which is these are in Minnesota work comp rules. They aren't part of the treatment parameters, but it's in the other sections that address work comp, states that the individual healthcare provider that's directing and coordinating medical care to the employee following the injury is the primary healthcare provider. So in a situation where you have an MD who is the primary healthcare provider and is referring the patient to a chiropractor strictly for chiropractic modalities, the MD would still be the one directing care. The MD would be the one outlining work status and workability forms. The MD would determine whether or not that patient needs to be referred on for any further treatment. And the chiropractor should be communicating with that MD, the primary treater, regarding the patient's response to treatment and what the chiropractor's recommendations are for ongoing treatment. There are also parts of the work comp rules that deal with return to work responsibilities of the primary healthcare provider. So if you are the primary healthcare provider, there's a workability form that must be completed either within 10 days of a request by an insurer or at every visit if the visits are less frequent than once every 2 weeks. So if you see somebody once a month, you want to be filling out a workability form at each appointment. If you're seeing somebody more frequently than once every 2 weeks, you want to give them an updated workability every 2 weeks. You definitely want to give them a workability form upon expiration of the end date on the prior workability note. So if your last workability note said these restrictions are effective until July 22nd, 2019, you want to make sure that that patient is evaluated and seen for an updated workability on or prior to July 22nd. Open-ended durations of disability or restrictions may not be given. Again, regarding report of workability, it must contain the employee's name, the employer and the insurer, if known, the date of the most recent exam. That's very important. You want to detail whether the employee is able to return to work without restrictions, with restrictions, or if they're not able to work. And the work restrictions should be stated in functional terms. If the person is not able to work full duty or they're not able to work at all, but they're able to work with restrictions, you want to state those in functional terms. You don't want to say, patient John Doe is not able to work on floor 101. You want to say what the restrictions are that they're able to, that they are not able to do, because then the employee can provide them work. It's not just to rule them out of a certain job area. You need to be stating these in functional terms. You also want to indicate the date the restrictions begin and the date that they will be reviewed, the date of the next visit, the signature and license number and ID information of the provider, and then there should be a notice on the workability form to the employee that the employee must be providing a copy of this workability note to their employer or work comp insurer and QRC. So takeaway from this presentation is, number one, providers are not automatically allowed 12 weeks of passive treatment for work comp injuries. That seems to be a misconception that we're hearing from some providers. There's also other criteria that must be met. The treatment must be medically necessary. Not everybody requires 12 weeks of treatment. The patient must show a response within a certain number of visits, and there must be a decreasing frequency of treatment. They must show improvement in 2 out of 3 areas: subjective, objective, and function. And as noted, not all work comp injuries require 12 weeks of treatment. If you have somebody that comes in with a very minor injury and you have somebody that comes in with severe symptoms, obviously one is going to, not both of them are going to require 12 weeks of treatment. Another takeaway from this is that the 12-12 rule is only included in the parameters for the low back, neck, thoracic, and upper extremity. And I put that in because I have had providers submit a request for treatment under the 12, or say that they're going to treat under the 12-12 rule for a knee injury. And it's not in the treatment parameters that this is, the 12-12 rule is present for lower extremity. It's strictly in the low back, neck, thoracic, and upper extremity treatment parameters. And thirdly, there are criteria that must be met for the provider to proceed with the 12-12 rule, and we've already gone over that. The other takeaway I'd like you to remember is massage. It's a modality that's allowed as passive treatment, but who can provide the treatment is restricted by law, as massage therapists are not licensed by a health-related licensing board in Minnesota. So that is it for my presentation. I want to thank you all for joining. Matt, I don't know if there were any questions at all.
Hi, Joanne. I don't think we received any questions. Let me just double check and make sure. Someone's asking if we can get the slides for the presentation. That was Chase Hawley. And yes, I believe so. We should have the email address on file. So I'm just going to make a note here that we'll. It might take us a few days to get that out to you, Chase, but we'll follow up and send you the slide deck. So
I noticed a couple of typos I had, so I might make some changes. But otherwise, yes, I'm happy to get the slide out. For sure.
And Lisa Morehouse, I see you are also asking. So I've made a note, and we will send out those slides to both of you in a few days.
Okay, wonderful. Thank you. Anything else?